I'll just share the screen.
Sure, doctor. And people will join as and when, so we can start. We can see your screen.
Okay. Should I start?
Yes, please.
Yeah. Welcome to all the participants. Good evening. So, as Dr. Sophia introduced me, I'm Dr. Priyanka Lekhwani, MDS, Pediatric Dentistry. So, I'm working as Assistant Professor in Dr. D.Y. Patil Dental College and Hospital. Today, I'll be speaking on the most reliable restoration in pediatric dentistry, that is stainless steel crowns, which is considered as gold standard for restoring in primary teeth, for restoration in primary teeth. You all must have heard a old saying that is said, old is gold. So if you must have heard about our ancestors saying that our हमारे time पे ये चीज कितनी अच्छी थी. Yeah, they always prefer what was there in the past. So same applies in dentistry also. So we'll take have you seen this meme where in the newer phones it is shown that when it falls it will break the screen, but when we go back to our Nokia old phones, when it falls it will break the floor. So the older things are much which are perform better. They are durable, they perform better, and simple solutions. Maybe the newer things are better, more aesthetic, more advanced, but the reliability and durability which the older things give are not given by the newer ones. So the best restoration in pediatric dentistry is stainless steel crowns. Now, what are these stainless steel crowns? Stainless steel crowns are prefabricated crown forms that are adapted to the individual teeth and cemented with the biocompatible luting agent. So, these are already preformed crowns, not like your prosto where you do proper tooth preparation, take impression, and then you send to the lab for the crown. These are already prefabricated, they come in different sizes. So, different companies provide different stainless steel crowns, uh, such as 3M, Kids Crowns, Oro Crowns, Rainbow Crowns. So we have crowns mostly for your actually for all the teeth, including your anterior and posterior, but most commonly used for your first molar and second molar. Here your D stands for your first molar and E stands for your second molar. And the quadrant is noted by your Palmer notation. Okay, and the sizes that comes, it ranges from 2 to 7. Okay. One size also exists, but it is not most commonly used, hence not marketed. So the sizes that exist are from D2 to D7 and E2 to E7 for all the quadrants. Okay. Uh, this is the stainless steel crown. So as you can see in the image, it is marked with the laser only. In the Palmer notation, you can denote the quadrant, and E stands for second molar and 7 stands for the size of the crown. So as I said, the crown sizes ranges from 2 to 7. So here the size is 7. Your crown also for the primary teeth, they are there only for all the teeth, and also for your first permanent molars, you have stainless steel crowns. So, what are the indications where you can give stainless steel crowns? So, whenever there are multi-surface caries, instead of doing all the surface restoration, you can go with a proper full coverage restoration, that is your stainless steel crowns. After your pulp therapy, you can give crowns after all your pulp therapy. In cases of your developmental defects such as amelogenesis imperfecta, dentinogenesis imperfecta, in cases of severe bruxism, high when the patient has high caries susceptibility, and it can also be given as your abutment to the space maintainer. As you can see here, this is a crown and loop space maintainer. So the space maintainer is attached to your crown itself, and hence it can be used as abutment to your space maintainers. So we'll go with for the methods for the crown placement. So there are basically two methods. What is used since past, that is conventional method, and one is Hall's technique. So your conventional method is divided again into two parts. That is your tooth preparation and crown preparation. So in prostho, like we only do tooth preparation, take impression and send to the lab. Whereas here, since they are prefabricated, you need to do your tooth preparation as well as your crown preparation for the placement of the crown. So your tooth preparation, the basic steps that will follow is your first is preoperative evaluation, where you will check the preoperative bite of the patient, preoperative occlusion. You can take a wax bite in this case. You will check the midline, you will check all the occlusion, and then you will proceed with LA administration and isolation using rubber dam. Next is your crown selection. For your crown selection, you have three methods. As we saw, we have different sizes of the crown. So we need to select a proper size of the crown for the placement of the crown. So there are three methods. First one is trial and error. You take random sizes from the box and randomly try on the patient. That is trial and error method. Second step is measuring the mesodistal width of the crown. Okay, so you will take a divider or vernier caliper. You will measure the mesodistal width of your tooth, mesodistal width of the crown, and then you will accordingly select and place the crown. Okay. The next, that is there are standard charts available where you have the measurement, what is the size of D2, what is the size of D3. So accordingly you can measure and check with your tooth size. So these are the three methods. Most commonly used is your trial and error method. So coming to the first step of your tooth preparation, that is occlusal reduction. Okay. After your pre-operative evaluation and isolation and local anesthesia, you will start with, and after selection of your crown, you will start with occlusal reduction. So occlusal reduction is done using your pear-shaped burr. Okay. So you will, occlusal reduction is not just flattening of your occlusal surface. You have to maintain the cuspal anatomy of your teeth while doing the occlusal reduction. So you will take a pear-shaped burr and you will go according to the anatomy of your teeth, you will reduce your cusp. So how much the occlusal reduction to be done? So different authors have suggested different dimensions for your occlusal reduction. For example, RAP suggested that only 4 mm of the tooth structure should be left above your gingival surface. Mink and Bennett suggested reduction of 1 to 1.5 mm. Kennedy suggested reduction of 1.5 to 2 mm. So which one do we follow? We follow most commonly, that is Mink and Bennett preparation, that is 1 to 1.5 mm of occlusal reduction. We don't do much occlusal reduction in primary teeth. So your next step is proximal reduction. Proximal reduction, you will take a taper fisher burr. You will keep that burr straight in the proximal surface. You will not give any bend or further taper because your burr already has that taper. So you will keep that burr straight in the proximal surfaces, and you will just you will just break and slice the burr through it, break the contact that much enough that you can pass your straight probe through it. Okay, you don't have to do much of the proximal reduction. Again, just break the contact so that your straight probe or explorer can easily pass through that space. Now again, here you can see the proximal reduction done. Again, you have different schools of thought. Some people say that you need to do occlusal reduction first, while some people say you need to do proximal reduction first. For example, Matthewson, Pinkham, Bink and Bennett suggested proximal reduction first, whereas Stewart's, Welbury, Forrester suggested occlusal reduction first. Now, why there is such difference in this? And what you should follow. So you should follow the occlusal reduction first, followed by your proximal reduction. Because when you do proximal reduction first, there are high chances that there will be gingival bleeding. So your vision will not be that clear because of the bleeding. So you need to first do your occlusal reduction. Then you know there is no pulp exposure and you are away from the pulp, and then you can start with your proximal reduction. So your vision will be clear, your field will be clear, and you can easily do your tooth preparation. Okay. So next, coming to your buccal and lingual reduction. Now the question arises, do we actually do buccal and reduction for your stainless steel crowns for your primary teeth? The answer is no, because we need that bulge of the crown. If you have seen a primary tooth, we have a good amount of bulge, and we need that bulge for the retention of the crown. So we don't do buccal and lingual reduction. In case required, we can do around 0.5 mm reduction on the buccal and the lingual surface, that too on the occlusal third. We will not reduce the bulge as it is required for the retention of the crown. So, as suggested by Mink and Bennett, you will permit the buccal and lingual cervical bulge to remain and reduce only the occlusal third of the preparation. Again, if it is required, then only we'll go for it. Otherwise, not required. So, again, we are done with the tooth preparation. Occlusal reduction 1 to 1.5 mm using your pear-shaped burr. Proximal reduction using your taper Fisher burr. You will just reduce that your straight probe or explorer pass through it. Buccal and lingual reduction, if required, you will do 0.5 mm. And now you will round off all the margins of the teeth. Okay, smoothen out everything. And then we'll go with crown preparation. So your tooth preparation, first part of your conventional tooth preparation is now done. And now we'll go for crown preparation. The first and the most important step in crown preparation when you take a crown is attachment of the crown. You need to attach the crown with floss or something so that the child should not ingest the crown. Okay. So there are different methods of attaching the crown. You can solder a hook on the crown to which you can attach the floss. Okay. You can solder attachment on the crown to which you will tie the floss. Okay. Now there are companies like Kids Ring Crown. They provide a ring already with the crown, as you can see in the picture. So there is a ring already to which you can apply the attach the floss. And once your tooth preparation is done, crown preparation and tooth preparation is done, you can just take a plier and you can just break the extension, that ring which is given. So it is easily breakable. Plus, it prevents the ingestion of the crown. After crown attachment, you will go with crown adaptation. So first step in your crown adaptation is trimming of the crown. For trimming of the crown, you can use your crown cutting scissors. So there are different scissors. You can use normal scissors also. So crown cutting scissors, you need to trim that, or you can use your burrs for trimming of the crown. So when you place the crown on the tooth surface, how much it should be below your gingival surface? It should be around 1 mm below your gingival surface. Okay. So when you place the crown, now how will you mark that 1 mm? You can see the marking on the crown there. So how will you mark that? You can place the crown. Okay. You can take a marker and mark, but that is not preferable because it will be washed away with your saliva. So what you can do is, when you place a crown, you can take a scaler and mark at the gingival surface. And after that, you can remove the crown. You can see where the marking is. Below one, you can leave 1 mm below that and then reduce your entire surface. For reduction, as I said, you can use your crown cutting scissors or your burrs. Okay. Next step is your festooning of the crown. Now this is festooning means contouring your crown as per your gingival margin. So for your first primary molar and second primary molar, you have different margins of the gingiva. So you need to contour the crowns according to that. Nowadays, the crowns which are available are already pre-contoured, but when you trim, you need to maintain that contour of the gingival margin. So how the gingival margins are there in your primary teeth? So buccal surface of your first primary molar is a stretched S shape. Lingual surface of your first primary molar is U shape, that is smile. Buccal and lingual surface of your second primary molar is again U shape, and the proximal surfaces are frown in shape. Okay, I'll repeat once again. So here, as you can see in the image also, So buccal surface of your first primary molar, it is stretched S. You can see this stretched S, it's going up. Okay. Lingual, first buccal surface of your second primary molar is U shape. Lingual surfaces of both the teeth are again U shape, and your proximal surfaces are frown shape. So you need to do the fish tuning according to these contours so that you can maintain the contour of your gingiva on your crown surface. Okay, so your trimming is again done as per these contours and fish tuning is done. So you'll follow these contours. Next step is your crown contouring. So you have different plier. This is known as Johnson plier. Okay, so it is a ball and socket type of plier. I can even show this plier in the video if you can see. So it is a ball and socket type of plier. So how you will do, you will keep this ball surface on inside of the crown and this surface on outside of the crown as seen in the image. Okay, so contouring is done basically on your middle third or near middle third and cervical third of the crown. Okay, in between middle and cervical third of the crown, and you will do on all the surfaces. Now basically what contouring helps in is retention of the crown. It will maintain the contours of your teeth, so it will help in better retention of the crown. So we can see a video of contouring. So you need to do contouring on all the surfaces, okay, in between middle and cervical third, so that you maintain that contour of the tooth, you maintain that bulge. Okay. Next step is crown crimping. Okay. Now you have crimping pliers, separate pliers for crimping of the crown. So basically your crown crimping, it is done on the gingival third of the crown. Okay, your gingival third, as you can see in the image, you need to walk through this plier. Okay, so it is done on the buccal and the lingual surfaces. Okay, you will walk through the plier entirely. Okay, you will not pick up the plier, you will just continuously walk through the plier. If you pick up in between, it will lead to formation of kink. So what is this procedure? Crimping helps for, it helps in protection of the soft tissues, prevention of your leakage of the cement, prevention and contamination, and adequate retention of your crown. So you'll crimp the all the gingival third. So contouring was done on the middle third, middle and cervical third, in between middle and cervical third, and your crimping is done on your cervical third. So basically, you need to just give a bend at the gingival third entirely without raising your plier. Okay, so this is your crimping plier. Okay, you will take it and walk through and the entire surface of the crown without any liftment. And how will you check crimping? Once your contouring and crimping is done, how will you check it? You can take a glass slab and you can place the crown over it, and you can check on the at your eye level that all the overall crimping is done or not. Otherwise, you can place the crown and you can take the x-ray, and where you can the margins are visible, you can easily identify where the crimping is not done, yeah, where the crimping is inadequate. So next, after your crown contouring and crimping, your crown preparation is also done. You need to polish finish all the surfaces. You need to soften all the surfaces, finish all the surfaces, and then you need to place the crown and check. So for seating of the crown, you cannot place the crown directly on the tooth surface. As I said, we need that bulge and we have not reduced that bulge. So when you place the crown directly, it will not seat. So for seating of the crown, stainless steel crown, you need to place the crown on the lingual surface first, and then you need to slide the crown on the buccal surface as seen in the image there. So you will check the fit of the crown at this stage after your contouring, crimping, festoning. You will check the fit of the crown. You will place from lingual to the buccal side. And how will you identify that if at this stage your crown is properly placed or not, properly contouring and crimping is done? While placing the crown, you will get a snap fit. You will get a tuck sound when you place the crown on the teeth. At this moment, if you get this sound, means your crown is very nicely placed. Okay, if you see at this stage, if you see blanching around your tooth surface, then you need to, there's an overextension, you need to remove the crown and you need to again do the trimming from wherever the surface you are getting the blanching. So once you get a snap fit, means your crown is now ready for the cementation. Once the contouring and crimping is done. So yeah, now your crown is ready for your cementation. You need to polish all the surfaces of your tooth after your tooth preparation and crown after your crown preparation. Okay, now you need to cement the crown. So the most commonly used cement for luting the crown is your GIC. You can also use your polycarboxylate cement, zinc phosphate cement, silicophosphate cement. Now, how you need to cement the crown? You will take the crown as you can see in this image. You will fill the crown, two-thirds of the crown, with your luting cement, properly placed, evenly placed, and then you will place the crown. Then you will ask the patient to bite on the cotton roll. So now you will remove your excess cement that was there after your crown cementation. So for removing your excess cement, you can use an instrument, okay, through which you can easily remove the excess cement, or you can use the floss from the proximal surfaces, as you can see in this video. So this was your conventional tooth preparation. I'll just quickly revise this conventional tooth preparation. So tooth preparation crown adaptation basically has two steps, conventional and your Hall's technique. We discussed the conventional one right now. So conventional, you will again divide it into two steps, tooth preparation and crown preparation. Tooth preparation, you will first isolate, you will give LA, you will isolate, you will pre-operatively evaluate everything. After that, you will start with your occlusal reduction, that is 1 to 1.5 mm. Proximal reduction, that much just to pass your probe through it. Buccal and lingual reduction, not required, in case required, 0.5 mm, followed by your finishing and polishing of all the surfaces. Then for your crown, you will attach the crown with the floss first. After that, you will do the trimming and festooning of the crown based on the gingival contours as we saw. After that, you will go with crown contouring, crown crimping, and then rounding of all the margins, removing all the rough surfaces, and then cementation of the crown. So this was all about your conventional technique where you will do properly tooth preparation followed by your crown preparation and then placement of your crown. Next is your Hall's technique. This technique was given by Dr. Nona Hall. Now, what is this technique about? Now, Dr. Nona Hall said that you don't need to do any tooth preparation. You don't need to remove any caries. Don't do any crown preparation. You just take a larger size of the crown that fits all on all the surfaces, and then restore it with your luting cement. Take the luting cement, mix it, and just restore it with the luting cement. Now, what was her ideology behind it? She said that not to remove any caries, not to do any tooth preparation, directly place the crown. So basically, this technique is done on the patients where the patient is not cooperative much, and you need to caries. The patient is highly caries susceptible, and you need to give crown, but the patient will not sit for that procedure completely for you to do the tooth preparation and crown preparation. In such cases, you can go with Hall's technique. So indications for this technique are caries should involve your enamel and dentine only, not even approaching your pulp. Okay. If the caries is in enamel dentine, then you can go with Hall's technique, and the patient is uncooperative. So, what are the advantages and disadvantages of this technique? The advantages, it is quick and invasive. No tooth preparation is required. No caries removal is required. No need of LA. No need of isolation. No need of rubber dam. And this technique is easily acceptable for the patients and the parents. You just don't have to do anything and just take a crown and cement it. So it was easily acceptable for the patient and the parents. Disadvantages include, as you are not removing any caries, you are not doing anything, so your caries might progress further, and it may lead to pulp pathology and difficulty in retreatment. If the patient pain starts, then again you need to remove the entire crown and you need to do your pulp therapy. Now, what was her ideology behind this, where she said that don't remove any caries, yeah, don't do any preparation, just do the crown directly? So basically, her ideology was that the caries progress because of your interaction between your bacteria and the carbohydrates. So you have break that contact only between you have break the nutrient supply of your teeth. So the bacteria will not progress further. So this was her ideology, but not ideal for all the cases. So to note that Hall's technique is a supplement to conventional technique, but it is not a substitute. Ideally, you need to remove the caries, you need to do the tooth preparation and then restore the crown. In cases where the child is not sitting, the child is uncooperative, and you need to give the crown, you can go with Hall's technique. So what are the basic advantages of your stainless steel crowns? And one more thing, in your Hall's technique, you will need a two-sitting procedure, and in your conventional technique, you will need a single-sitting procedure. Now, why two-sitting procedure in Hall's technique? First time when the patient comes, you will place the separators so that the you get a separate the proximal contact of the teeth. And next time when the patient comes, you can directly lute the crown with the luting cement. Whereas in your conventional, you don't need to call patient twice. You can do complete the procedure in single sitting. So advantages of your stainless steel crown: less time consuming है. You don't need any laboratory procedures for that. You don't need to take impression and send it to laboratory. They are pre-formed. You have different sizes available. You can select the size, and you can cement it on a single day. Can be completed in single appointment. The stainless steel crowns are durable as compared to other multi-surface restorations. If you must have seen the failure of your GIC or composite, especially on the proximal areas. So multi-surface restorations or your proximal restorations prefer a stainless steel crown, giving full coverage restoration, and it is cost-effective method. The only disadvantage of your stainless steel crown is your aesthetics. Okay, and there are multiple modifications of your stainless steel crown they have given for your aesthetics. If you must have heard the facial cutout. So after placing your stainless steel crown, what you can do is you will cut this buccal surface, and then you will place a composite restoration. So it becomes aesthetic, and plus the strength of your stainless steel crowns. Next are your pre-veneered crowns, where resin is already incorporated over your tooth surface, like your PFM crowns. So the only disadvantage of your pre-veneered crowns are they cannot be contour and crimp. So again, the entire retention is based on your cement, not on your tooth or the retention which we tried to maintain for your during your tooth preparation. So pre-veneered crowns are aesthetic, but they cannot be contoured, they cannot be crimped. You need to, the retention will be based on your chemical adhesion only. Plus, over a period of time, due to occlusal forces, the resin chips off. So there's the exposure of the metals. So every procedure has a complication, of course. So what are the complications for your stainless steel crowns? So suppose your crown placement is done. While checking during that snap fit time, you see that the crown is rocking. Okay, you need to figure out where the problem is. So if your crown is rocking, there is something, some error related to your occlusal reduction. Your occlusal reduction is not uniform. So you need to go back, check your occlusal reduction, properly do that again, and then place the crown. Okay. So if your crown rocks, there's an error with your occlusal reduction. Suppose you are placing the crown and the crown is not seating properly. It is again and again bouncing back. So there is a interproximal ledge in this cases, which is not allowing your crown to seat properly. So you need to go back, remove the crown, go back and check your proximal reduction. Okay. Proximal reduction is checked properly with your explorer and probe. You need to remove the ledge, you need to properly pass your straight probe or your explorer. It should smoothly pass without any hindrance, means your proximal reduction is now fine. Suppose there is a crown tilt. When you place the crown is tilted towards your buccal or the lingual side. Now here the problem is, maybe there was caries on the buccal on the lingual surface, or buccal and lingual surface reduction is being done, so the crown is tilted towards one side. So what here you can do is, you can, where the caries was there or where the preparation has been occur more, you can build that surface with your composite restoration, make the tooth surface proper, and then seat your crown. Okay. If after placing the crown, if you see blanching, blanching is basically whiteness that you see after placement of the crown. It is basically because of the pressure. If you see blanching on the gingival surface after placement of the crown, means the trimming is insufficient and there is extension of the crown, overextension of the crown. So at this time, you will remove the crown back and then you will again trim it. As we saw for the method, you will take a scaler, you will mark the gingival contour just 1 mm below your marking, you will keep, and you will reduce all the entire surfaces. And if you find blanching even after that, you need to find where the blanching is, you need to remove the crown and you need to trim from that surface and then place the crown back. So these are the normal complications which you can get and that can be rectified. The most common complication that can occur is your ingestion of the crown. So if the first thing to prevent that, we have attached the floss to the crown. So even if the child ingests the crown, you take the floss and pull the crown back. Suppose the child ingested the crown. Now how you can, what you can do at that cases. So you can ask the child to cough out loudly and remove that foreign particle from the mouth. Okay. If that does not work, you can take the child, if the child is small, you can take the child, you can turn him upside down and you can tap his back for the foreign body to remove from the mouth. And even if that does not work, you can try the helmet maneuver. We'll see the what is it in the video. First step to trial such situations is asking the child to cough. Coughing is a effective way to push him. If the answer does not work, stand beside the child and hand them cough. Use on the hand of your hand. So as we saw in the video, we can try removing the crown in that way. So first of all, we need to prevent the ingestion. You need to tie the floss. Okay. Floss can be, again, you can tie using your glue also, but again, it is not a reliable method because glue will be washed off using your in your saliva. So better to attach a hook, or you take such crowns which already have the ring, attach the floss. Next, if the child ingests, ask the child to cough out or tap the back of the child, or you can try this maneuver. Suppose even if after all this the crown is not removed, then you will ask the patient to go to the medical emergency and ask him to take a chest x-ray. So in the x-ray you will get to know what the exact location of the crown is. Okay. If your crown after the injection, if in the x-ray you can see the crown is in the digestive tract, so you can ask the patient to wait. It will just pass through the stools after maybe within 2-3 days. Okay. If you see it in the respiratory tract, to be operated and removed immediately. So complications are there in all the restorations. Every restoration has complications, but only few offers reliability and longevity. Even after years, the stainless steel crown was given around in year 1947. Even after years, the today stainless steel crown is still the most reliable restoration for your primary teeth. There are multiple studies, multiple newer crowns that come. They are good, of course, they are good aesthetically, maybe strength, but the what strength the stainless steel crowns give, yeah, what retention the stainless steel crown gives is not provided by other restoration. So the stainless steel crown still today remains gold standard in pediatric dentistry. Thank you.
Thank you so much, Dr. Priyanka. It was a very compact session, very, very insightful. Thank you so much.
Thank you.
So, we do have a couple of questions. Can we take them?
Yeah, sure.
So, what's the name of the contouring forceps?
It is known as Johnson's contouring plier. Number 114, Johnson's contouring plier. So if you search in dental cart also, no, contouring plier, you can easily find that. I guess it's around 1500 to 2000. So it depends on company to company.
Right. They're requesting you to just repeat the gingival contour slide.
One sec. I'll just share again.
Yeah.
Can you see my screen?
Yes, doctor, we can see your screen.
So this step is basically festooning, where you contour the crown as per the contour of your gingiva. So when you see in the patient also, the gingival contour is like that only. As you can see in this image also, I'll repeat that, but just showing this. So your first molar, as you see, this is the first primary molar. So the gingival contour is S shape. That is, see, you can see this stretched S. It's going down and going up. This is your first for your first primary molar, and for your second primary molar it is U shape. So you need to trim or festoon the crown according to this shape. The crowns now that are available is in this shape only, so you need to just follow that. But previously, when the crowns were introduced, it was just a box shape, so you need to prepare that contour of the gingiva. So even if now you are doing trimming or contouring, you need to follow this contours. So buccal contour, as we saw, buccal contour of your first primary molar is S shape. Lingual contour of your first primary molar is U shape. Buccal and lingual contour of your second primary molar is U shape. Whereas when you do proximal festooning, it is frown shape.
Right. I think you all can take a screenshot of this slide. Moving on to the next question, Dr. Priyanka, do we need to give LA for tooth prep and stainless steel crown placement in conventional technique?
Yes, you need to give LA prior to it because you are going to impinge on the gingiva and thing, and sometimes you are giving on the vital teeth, so you need to give LA.
Thank you so much. Any other question, doctors? I think we are at the end of our questions, Dr. Priyanka.
Okay.
It's very nice of you to take all their questions. And again, lovely session, I must say. And I'm really looking forward to the next one.
Thank you so much. I hope it was helpful to them for the placement of the crown.
I'm sure it was, I'm sure. So thank you so much. And thank you so much, doctors. I have put all our upcoming lectures in the chat box as well as on the group. So in case you wish to join our community group so that you have better updates, then please text us on this. We will add you to our community group. Thank
Thank
you,
you so
doctor.
much to all the participants.
Yeah, they are saying very informative session.
Yeah. Thank you. Thank you.
All right, doctors,
Thank
I'll
you.
see you in the next one. The next one is on 5th. It's on Sunday in the morning. It's on Demystifying Ankyloglossia by Dr. Manisha Nair. So there are links given in our profile bio. Please go register yourself and I'll see you on Sunday. All right, thank you so much. And
Thank
I'll
you
see you.
so much to you also for coordinating the session very
Thanks.
nicely. Thank
My
you.
pleasure, doctor. Thank you.
Thank you. Bye.